This video is on hyperosmolar hyperglycemic non-ketotic state, short form HHNK. This video is part 2. Part 1 is on diabetic ketoacidosis, which is always related with HHNK, and I have uploaded the video on DKA previously, so you can go check it out. So for HHNK, which will be more focused in this video, the diagnostic criteria includes blood sugar that is high, more than 33 millimole per liter. Serum total osmolarity is significantly high, which is more than 330, and there is absence of ketonuria or ketonemia. So this is very important because to differentiate from DKA, DKA has ketonuria or ketonemia. Hence it's called diabetic ketoacidosis, whereas HHNK doesn't have this. So some points to take note for HHNK: it has a longer disease course, which is days compared to hours in DKA, and for this HHNK, there is more severe dehydration, greater potassium loss, patients are more sensitive to insulin, so less insulin is required, and it has a higher mortality rate compared to diabetic ketoacidosis. These are some of the causes of hyperosmolar hyperglycemic non-ketotic state. So HHNK can be caused by infection, intercurrent illness, infarction, for example, myocardial infarction, also known as heart attack, or shock events, insulin errors, for example, wrong dosage of insulin injection or missed dose, and also dehydration. The clinical features of HHNK include symptoms like hyperglycemic symptoms, where the patient complains of polyuria, a lot of urine, polydipsia, always very thirsty, and also loss of weight. Dehydration symptoms, for example, postural giddiness, which means the patient was sitting down and suddenly stand up, they will have giddiness, and also weakness. They might complain of altered mental state, where they are confused of their surroundings, and also the symptoms depend on the underlying etiology of the HHNK state. So if it is due to infection, for example UTI or URTI, they may complain of fever or localizing symptoms. If it is due to infarction, for example myocardial infarction, they will complain of chest pain, shortness of breath, diaphoresis, which is profuse sweating, palpitation, syncope, and if it is due to cerebral vascular events like stroke, they can complain of focal neurological deficits. Okay, and other etiology include insulin errors, so have to ask full history, especially if the patient has diabetes, ask whether he is compliant to the medicine or insulin injection, and ask whether he missed any dose or increased any dosage. Other signs of HHNK state is, like I said, altered level of consciousness, where we can assess using the GCS score. We should also look at the vital signs, and there will be dehydration signs, for example, reduced skin turgor, sunken eyes, increased capillary refill time, and so on. And to check for the etiology, underlying etiology, we also have to do full examination, which includes respiratory examination, cardiovascular, and also neurological. So some of the investigation we can do when we suspect for HHNK: to confirm the diagnosis, we will have to do plasma glucose, check the serum osmolarity, check whether there is any urine or serum ketone to rule out DKA, and also arterial blood gas analysis to check for metabolic acidosis. Okay, and also to assess the severity, we can do Beals and creatinine, and to check for the underlying etiology, we do ECG and cardiac enzymes to rule out myocardial infarction, chest x-ray, look for any signs of upper respiratory tract infection, full blood count, blood culture and sensitivity if the patient looks septic, and also UFIM and urine culture and sensitivity to rule out UTI. So moving on to the management of HHNK, we divide it into supportive and specific management. So for supportive measures, first, when the patient comes to the emergency department, we have to assess the patient's vital signs and also resuscitate if it is necessary. So we check the airway, breathing, and circulation. And also, after that, after the patient is stabilized, we have to monitor the vital signs, which include strict input and output chart, and also monitor the other vital parameters like blood pressure, pulse rate, respiratory rate, SpO2, and so on. And also do necessary investigations like I mentioned just now. For specific measures for HHNK, these are the 5 principles we have to do. First one is the intravenous volume replacement, and this is actually more important due to greater fluid loss compared to DKA. It's more important in HHNK. And other measures include potassium replacement and also restoration of the electrolyte imbalance, insulin administration. In HHNK, we do not need to give bolus insulin because the patients are sensitive to insulin, unlike in DKA. Okay, and the fourth is treat possible complications. For example, some of the complication might be thromboembolism. So we have to give subcutaneous low molecular weight heparin until the patient is able to be mobile. And also treat precipitating factors. For example, if there is sepsis, we give antibiotics. If it is due to acute myocardial infarction, we can do MONA, which includes giving morphine, oxygen, nitroglycerin, and also aspirin. So let's look at the complications of HHNK. So some of the complications include fluid and electrolyte imbalance, congestive cardiac failure, acute renal failure, and also thromboembolism that might further cause deep vein thrombosis, pulmonary embolism, acute myocardial infarction, and also cerebrovascular accidents like stroke. Whereas the treatment can also have some complications, for example, cerebral edema due to over rapid correction of the fluids, due to use of hypotonic saline, or due to rapid correction of the hyperglycemia. So we have to take note and look out to not correcting the fluid too fast. And other complications include hypoglycemia, hypokalemia, and also hypophosphatemia. Okay, that's all for HHNK, and this last slide over here, I have included this table which shows the difference between HHNK versus DKA. So these two are closely related to each other because of their similar clinical presentation. Okay, so if you look at this table over here, the plasma glucose in HHNK is significantly higher, which is more than 33, whereas for DKA is more than 14 millimole per liter. And then take a look at the osmolality. HHNK has a higher osmolality, which is more than 330. And for pH value, DKA is actually acidic, whereas HHNK is more than 7.3, less acidic. And for the HCO3, the bicarbonate level, DKA is less than 15, HHNK is more than 15. So these are some of the differences you can take note. And if you look at the fluid loss, there is more fluid loss in HHNK, and the mortality risk is markedly increased in HHNK. Okay, so that's all for this video. Thank you.